Good morning, guys. This is Miss Jumper. Happy Monday morning that you're off and not in school. I'm going to record our dermatology lecture and post it to you guys for you to watch before class. I'm going to try to keep this really short, 30 minutes or under. This is the third time I've tried recording it because my kids keep running in here and I have them bribed to stay in their rooms for a few minutes while I get this recorded. So I will try to be very brief and get this posted so that you guys can watch it before class. So I'm going to share my screen with you guys. And let's get started. So we're going to talk about care of the patient when they have an infectious disease. So in general, or skin condition, infectious disease, though skin or skin condition. So in general, with these patients, we want to make sure that we're trying our best to maintain skin integrity. They may not always be able to successfully keep the skin intact, but to maintain the integrity of the skin as best we can, because the skin is our first layer of defense. It's what keeps all the nasty stuff in the world out, right? Promotion of basic care and comfort. So rest and sleep and pain control are really, really important for these patients, especially pain control, because we have so many nerve endings in our epidermis and our dermis that a lot of these skin conditions are extremely painful for our patients. So yes, we need to know that, oh my gosh, what's a medical emergency? What am I going to do? What are the nursing interventions for that? But don't forget about the basics, basic care and comfort for our patients, promoting that. On the HESI, you guys did really, really great in some areas, but basic care and comfort was one that kind of overall, not even just this class, but classes before historically, and even on the NCLEX have scored low in those areas. So I really want you guys to kind of think about, remember, probably unless you work in a trauma or ER in an inner city, you're not going to see those medical emergencies every day. Your day-to-day practice is going to focus on those basic care and comfort needs of your patients. Avoidance of complications, which would be a systemic infection. So, our skin obviously was not able to keep the infection out, and then it travels inside. And then also the self-acceptance and body disturbance images, because a lot of these issues are going to cause those body disturbance images for your patients, because obviously, we put a lot of thought into ourself as far as the way we look. So we're going to need to also help our patients with that, or know that they're going to go through that and struggle with that, and that's normal for them. So infectious diseases of the skin, again, there's a bunch of these listed in the book, and I'm not going to cover them all. I'm going to go over the two that I think are the most important for you guys to know. Impetigo, you've probably covered this in pediatrics, but we're going to briefly talk about it again. This is a superficial infection of the skin that's caused by staph or strep. Those are the two most common ones. It can be caused by any bacteria, but most common ones. It also most commonly affects children, but that doesn't mean adults can't have this as well. Kids are just gross and they don't wash their hands, and things spread really easily between a group of children, whether that be in daycare or school or wherever. So these lesions are most often seen on the face. They can also be seen on the extremities as well. They begin as small red macules, and then they leak a thin secretion that then crusts over it, and it's like a honey colored crust. So when we're treating this, we treat with topical antibiotics most often, and we want to make sure that we get those crusts off before we put the antibiotic on. So you would educate your patient to use a warm washcloth and sit it on those crusts and soak those lesions, and then they should be able to get that crust off pretty easily without a lot of pain and scraping. But we want to get all of that old dried crust off before we put the antibiotic on, right? Because we want the antibiotic to get on the surface of that macule to be able to absorb and to treat that. If we're putting it over top of the crust, it's not going to be as effective. So that's really important that we teach the patient and her parents how to do that effectively. Meticulous hand washing for the family, the household, the siblings is really important, because this can spread very easily. They don't want to share towels, washcloths, toys, anything like that. They kind of need to treat it as this is an infectious thing, like, if you have the flu. So we want to isolate those people. If they were in the hospital, we would put them on contact precaution. So that's kind of the thought process we need to go through when we're educating them on how they need to keep this from spreading. If it's severely, if it covers like a large surface area, then they may put them on oral antibiotics. And so topical antibiotics are going to be the most common treatment that you see, but they can prescribe oral antibiotics just depending on the extent of the severity. They can also bathe daily in antimicrobial soap. So all over their skin, just take a bath from head to toe in that antimicrobial soap, and that is will help as well. Nursing management, we just want to educate the patients again on how to take the medicines, how to treat the skin, how to bathe, how to prevent it from spreading, to take the full course of antibiotics, whether that be topical or applied. These kids are going to need to stay home from school until they're no longer infectious. So with your topical antibiotics, that's going to be 48 hours. And if you're on oral antibiotics, that's 24 hours from the time you start those treatments. So they'll need to stay home from school or wherever they need to stay home so they're not spreading it. It's really important that we make sure that they know that they continue that. So if the lesions start to get better, you still need to apply that antibiotic or take that antibiotic orally. Obviously, we know we always educate our patients that you need to continue the full course of antibiotic to prevent bacterial superbugs, right? I mean, we always tell them that that's really important. And I know pretty sure I heard the Hearst lady mention this, and we haven't gotten into this yet, but when we have untreated strep bacteria in children, this can lead to glomerulonephritis, which is a secondary infection. So it's really important that we treat this properly with antibiotics. Nursing management, again, education, meticulous hand hygiene. Okay. Herpes zoster or shingles. So herpes zoster is also called shingles. It's an infection caused by the varicella zoster virus, or chickenpox virus, as most people know it. So this is caused by a reactivation of the varicella zoster. So a patient has been infected previously with the chickenpox or the varicella zoster virus, usually as a child. And then it lies dormant in the cells near the brain and the spinal cord. And then certain things can trigger reactivation of the virus. So stress, fatigue, poor nutrition, decreased immunity, those can all trigger reactivation of the virus. So stress, fatigue, poor nutrition. Does that sound like that's ringing any bells for you guys? Like, as a nursing student, you probably experience all those, and I feel like every year we have at least one nursing student that has a shingles breakout. So take care of yourselves, get some sleep, and eat good. try to not get shingles while you're in nursing school. But those things can cause reactivation of the virus. And what happens when that virus reactivates is it travels along that nerve path, along the peripheral nerves into the skin, and it is going to run horizontally along that dermatome. So there's three phases. We have our pre-eruptive phase, which is when the virus is reactivating and the patient may complain of some pain or paresthesia over that sensory region of the dermatome. And then we have our acute eruptive phase, and that's when the vesicles appear. They're initially thin, and then they'll rupture and have a crust on them. And the patients are considered contagious until those lesions are no longer like having that thin secretion that they've actually crusted over. So during that time period, when you have the pre-eruptive phase and the eruptive, active eruptive phase, before those lesions crust over is when the patient is considered contagious. So if they were in the hospital, then we would put them on contact precautions, and those people that need to avoid exposure are those who are unvaccinated or never had the chickenpox, or those who are pregnant would need to not care for these patients or avoid exposure. And then we can have the post-herpetic neuralgia phase, which is when they continue to have that pain over the area of infection for well past when the actual like lesions go away, because we have that sensitivity with that nerve path or that dermatome, and that patient continues to have pain in that area. So like this lady right here in the picture, she has this lesion over her eye. She could potentially have that post-neuralgic pain, and it's going to be right where those lesions were over that dermatome. That bundle of nerves on her face can still be inflamed and very painful for her, even after the lesions are gone. Another thing to consider is especially and that's why I use this picture, because you can see this is on her face over her eyes. And this can lead to blindness in these patients or vision impairment. So it's really important. This particular patient may be hospitalized and on IV corticosteroids to help inflammation and to monitor. So we need to be careful and cognizant of that. The treatment is with the oral antiviral agent, so acyclovir, valsaclovir, and then corticosteroids. And the quicker that you can get them on that acyclovir, the better. A lot of people who have like the herpes simplex, so the cold sore, they can tell you they kind of feel like a tingling coming on before that cold sore. And if you take acyclovir, like I'm a herpes person, so I get cold sores all the time. I've had them since I was a little kid. But I can feel when that like tingle comes on, and I have a prescription for acyclovir, and so I can just take those acyclovir, and usually I can prevent it from erupting. Sometimes not, just depends on what's going on. But for shingles, if you can get that acyclovir started before it hits that acute eruptive phase, then that's really the best course of treatment, and it's going to limit the severity of the illness for the patient. And a lot of people have not had shingles just once, but had shingles multiple times. And so after they've had it the first time, they kind of know, hey, like, I feel like I've got shingles, starting again. I've got that pre-emergent paresthesia and pain. And sometimes it can occur along that same dermatome, or it could be a different dermatome, but it may occur along that same one. So they may like feel like, hey, I feel like it's coming on again. And the quicker we can get them started on that antiviral, the better outcome for them. All right, so like I said, I'm not going to spend a lot of time on some of this. I feel like some of it's kind of self-explanatory, or maybe you have seen, too far back. Maybe you have seen some of this previously in your fundamentals, but here's our fungal infections, the different type of fungal infections we have. Obviously the Tinea corpus, which is the ringworm. So it's not actually a worm, but it's a fungal infection that causes that ring, or that circular rash. The Tinea capitis, think about your medical terminology. That's going to be on the head. The Tinea pedis, that's going to be on the feet. The Tinea curious, or curus, be really careful when you Google that, because I Googled it to put pictures in the slideshow, and I was like, oh my gosh. And then like my kid was walking past the computer, and he's like, Mom, what are you looking at? I'm like, I swear it's for school. So just be really careful and who's in the room when you're Googling that stuff. But obviously that is referred to as like jock itch, but that's going to be the fungal in the groin. Okay. So obviously we're going to treat these with our antifungal creams. These are good usually indenzols, or your econazole, your ketoconazole, those type of medicines. So all I can think of when I think of like athlete's foot is this guy, and you guys are probably too young to remember this, but there was a commercial back in the 90s. Yes, I know I'm old, where this guy he advertised a medicine called Tinactin. And he's like, you got an athlete's foot, you need Tinactin. And that's all I can think of. So if you want to travel down memory lane, you can Google that commercial, and it's pretty funny. But anyways, Tinactin. Sometimes those things just stick with you, and you never forget it. So I'm like, hey, I know Tinactin is an antifungal cream, even before I was a nurse. So we want to instruct them on the use of oral and topical agents and shampoos if it's the Tinea capitis, instructing on hygiene, using clean towels, not reusing your towels or wash rags. Don't share your towels. When you get out of the shower, make sure you fully dry off, get in between your skin folds. Wear clean, dry cotton clothing, including your underwear and socks. A lot of athletes, suffer from this because they do sweat a lot, and then they're in that uniform and they don't wash it, or they don't wash their gym towels, especially teenage boys. They can be so gross, and I have two of them coming up, so I'm sure I'll deal with this at some point as a mom. And then that excessive heat and humidity, hair loss associated. So we just want to educate them on those treatments for that. You guys can read over that more in your book if you want. Okay, this is what gave me the heebie-jeebies. I was not looking forward to this part. I think like as nurses, we don't bat an eye to C. diff or different other things, but you talk about lice scabies, we're like putting on the full hazmat, right? Because we're like, I am not getting that. I'm not taking that home. I'm not taking bugs home with me. I don't want bugs on me. Like even just talking about it, like start itching. Right. We have the parasitic skin infections. Like I said, I'm not going to spend a lot of time on this. The lice can occur on your head, your body, or groin. This is going to cause intense pruritus and scratching, obviously often leading to a secondary bacterial infection of the skin, like the impetigo. We're going to treat with that pyrethrin, medicated shampoo, those treatments for lice. Everything has to be washed, clothing, bedding, and hot water. Combs, brushes, throw them out if they can. If not, they need to be disinfected. And then our scabies here is we have mites, and those burrow into the skin and lay eggs. This is like the stuff of nightmares, guys. They burrow into the skin and they lay eggs. And then those eggs hatch in 3 to 4 days, okay? Actually, it takes them 4 to 6 weeks to lay eggs. So once they burrow in, it takes 4 to 6 weeks to lay the eggs, and then those eggs hatch. And they're going to have those small erythematous papules, and they're going to kind of just be clustered together. This is going to cause severe itching, and it's going to be worse at night. So if you're interviewing the patient and they have a rash and severe itching and it's worse at night, that should clue you into this is probably scabies. So I need to look closer. We're going to treat this with the topical permethrin or ivermectin. It's also called a scabicide, which is a really fun word to say. I'm like, oh, I could say that. Scabicide. This is going to occur most often in the webs of the fingers, the axilla, and the genitalia. Again, just like lice, everything has to be washed in hot water, hot water. Instruct patients to take warm soapy baths, allow their skin to cool, and then apply that prescription scabicide medication. Heebie-jeebies, guys. Okay, psoriasis. So psoriasis is a chronic autoimmune inflammatory disease of the skin. Okay. And what happens in this skin condition is we have epidermal cells that are produced at an abnormally rapid rate. So normally our skin goes through a cycle and we produce so many skin cells a time, but this is like abnormal overdrive production of skin cells. So what we have is this raised silvery looking kind of it's well demarcated. So what does that mean? That means that you can tell a difference between where it starts and where it ends. So obviously I could draw an outline through this. It's well demarcated. So if you ever hear that term, that's what that means. You have our erythematous plaques, which are red. So this is going to be red plaques, and it's going to have a silver scale. So you can kind of see they refer to it as a scale, but it's kind of a whitish or silver color. This is most common on the scalp, the knees, the elbows, and the gluteal cleft. Our patients can go through periods of remission and exacerbation of the psoriatic lesions throughout their life, and it can be aggravated again by stress on the body. So stress, trauma, seasonal. This is going to be worse in the winter because the air is dry, we lack that moisture, and we also have lack of exposure to the sun. And so actually phototherapy is a treatment for this, which we'll talk about in just a second. And hormonal changes can affect this as well. In limited cases, so where it's covering a small surface area, so maybe you have just a patch here and a patch there, it can be treated with topical corticosteroids, emollient creams, and topical retinoids. So azoretine, this causes a sloughing of the scales that cover the psoriatic plaques. So that's how the retinoids work. It causes increased sensitivity to sunlight by loss of the outermost layer of the skin. So the patient should be cautioned to use effective sunscreen when they're using these topical retinoid creams. And then when we have severe systemic, so it covers a very large body surface area, then we are consider some other treatments. So methotrexate, which is an immunosuppressant, because remember this is a chronic autoimmune inflammatory disease, so it can be treated with the immunosuppressant. But again, you have to weigh the benefits versus the risks. So how is the patient's daily life? Are they covered in these, or is it just one spot on their knee? So like I said, this is typically reserved for those severe systemic lesions. And again, retinoids and phototherapy. So you can see this picture here. This is a phototherapy booth, or can be used for a number of things, but this is typically used for these type of disorders. And so again, what the sunlight does is helps break down that outermost layer of the skin, basically. So it improves the, oops, too far. Okay, so it improves the lesions. That slow, rapid turnover of the epidermis, and promotes resolution of the psoriatic lesions. So we can educate our patients to remove the scales during bathing using a soft brush, apply that emollient or that topical cream afterwards, and maintain routines. So phototherapy, that UV light, that slows down the creation of the skin cells. So one thing we want to educate them when they do the phototherapy is protect their eyes. So make sure they have goggles on, just like when we have little jaundice babies. When we put them in the blue light, we have to protect their eyes. So same thing, they're going to wear goggles when they come in here. So that is a very quick overview of psoriasis for y'all. All right, and then the next one we're going to talk about is atopic epidermal necrolysis and Stevens-Johnson syndrome. So Stevens-Johnson syndrome and topical epidermic necrolysis are kind of synonymous, or one and the same term. These are considered a medical emergency. This is an acute immune condition, and this is most likely caused by oral intake of medications. Anti-gout, anti-seizure, antipsychotics are the most common culprits for this. Some specifically allopurinol, Tegretol, Dilantin, meloxicam, Zoloft, and sulfa antibiotics. Those are really common ones that can cause this. But what you are going to see is the patient's going to at first have flu-like symptoms. So we may have fatigue, fever, headache, cough, those type of things. And then it's going to be followed by painful red and purple rash that spreads throughout and causes blisters, and then skin sloughing. So we're going to see these blisters, and they affect the mucous membranes as well. So it affects the skin, the mucous membranes, and the genitals. So we're going to see, I keep past that because my mouse is strange. Okay. So you can see in this girl's mouth here, it's just crazy. And then like the skin is sloughing off on the lips. So if we think about it, yes, our oral cavity is a mucous membrane, but then our esophagus as well. So these people are going to be at risk for fluid volume deficit, because obviously they're not going to want to eat and drink, and then malnutrition. So a lot of these people are going to, in this severe stage, are going to need tube feedings and fluid replacement. Risk factors. Some studies show that there's a genetic component to this. Those are of Asian descent are more at risk, or if they've had a history of a viral infection such as herpes, or those who are immunocompromised. And you can actually get a test done to see if you have the gene that puts you more at risk for this. So that's interesting. So if you maybe have a family or someone that's related to you, closely related to you, that's had this before, they even suggest you get tested to see if you have that gene. So with a mucosal damage, there can be damage to the larynx, bronchi, and esophagus from those ulcerations. Obviously, these patients are going to be high risk for infection, right? Just think if you're losing all of your skin and it's sloughing off like that, this is going to be treated very similarly to partial thickness burns. I mean, we're losing our whole epidermis and dermis here. So we want to help with meticulous oral hygiene for these patients. We want to keep the mucosa clean. They can use chlorhexidine mouthwash and anesthetics, mouthwashes to numb the mouth so that they can try to attempt to drink and eat. We want to inspect the oral cavity frequently, and we can apply petroleum jelly or lanolin to the lips because they're just going to crust and slough off. You can see how painful that looks for these people in this in these pictures. Strict asepsis is very, very important. We're going to treat it like a burn patient. We're going to have sterile gloves, sterile sheets, sterile environment because they've lost their outer layer of skin. Another thing that can be a problem here is our eyes. So obviously we have mucous membranes in our eyes, right? Our conjunctiva. So they can have problems with their eyes. So we want to watch for reports of pruritus, burning, and dryness with the eyes. We can apply cool, dry cloth over the eyes to help relieve burning, apply eye lubricants, and even patches. Because if they're losing skin and everything's inflamed, they may lose the ability to kind of blink and keep their eyes lubricated. And so they can have corneal abrasions, corneal ulcerations, and then keratoconjunctivitis is the medical term for the problem that can occur with the Stevens-Johnson syndrome in the eyes. We can apply powder to the sheets to keep their skin from adhering to the sheets and pulling it off. We want to monitor for those signs and symptoms of thermoregulation, so hypothermia, just like with our burn patients. And then again, skincare is going to be that similar to that patient who's had a burn injury. I'm going to stop my screen share for just a second. Okay, sorry about that. All right, I'm going to share that. Yes, okay. So, no, wrong screen. Okay. So that's Stevens-Johnson syndrome. It's a medical emergency. It's going to be treated similar to a burn. The things we need to watch for are eyes and mouth, so monitoring those closely, and prevention of infection. Skin cancer. This is the most common type of cancer. I know we've talked about cancers along throughout every chapter. When we're breaking things down into body processes, there can be cancer with any body process. So we're going to talk briefly about skin cancer. Again, it's the most common kind of cancer. It's frequently related to sun exposure. I want you guys to look over in your book and look at those prevention strategies for skin cancer. We want to use sunscreen, avoid prolonged sun exposure. Prevention of skin cancer involves protection from excessive sun exposure and tanning. Okay, and here's a picture of some of the different types, and we're going to talk about basal cell, squamous cell, and melanoma in particular. So basal cell carcinoma, you're going to see this on the sun-exposed areas of the body, such as the face, neck, hands, scalp, ears, back of the ears. This is the most prevalent type, but rarely causes death and rarely metastasizes. It's going to appear as a small waxy nodule, can be shiny, flat, grayish, or yellow. And reoccurrence of these lesions are common. The treatment is excision and removal. Pretty easy. The squamous cell carcinoma is a malignant perforation that arises from the dermis or the epidermis. It's going to appear in those sun-damaged areas again, like your face, your ears, your neck, those areas that are exposed more to the sun. But these can metastasize if not caught and treated earlier. They do appear a little bit different. They're rough, thick, and scaly, and their border is a little bit wider and has more kind of an inflammatory area around it than the basal cell. So if you remember on that basal cell carcinoma, it kind of looked just like one little spot and it wasn't inflamed around it. Versus the squamous cell, we can see that spot, but then you see all the inflammation around it, which they have circled here. So this is going to require surgical excision. They may even do radiation or a topical chemotherapy cream, depending on the extent of the lesion. Okay. And then we have melanoma. So when we're assessing for, is that a mole or a melanoma? So here's your ABCDEs of assessing for that. So asymmetry. So one half of the mole does not appear to match the other. So we would look at the mole and see, okay, is it round on this side, round on that side, or is it round on one side and squiggly on the other? So if it's not symmetrical, then that's a high risk red flag for melanoma. Bordered. Do the edges appear irregular, ragged, notched, or blurred? So if we've got a smooth border here versus this one looks kind of like an ink blot, right? So we don't have smooth edges or borders. Red flag. Color. Is the mole not evenly colored? It may include shades of brown or black or patches. So obviously this is kind of all one color consistently, and this is like a variation of different tones of colors. Again, red flag. Diameter, the spot's larger than 6 millimeters across. So we measure it, this is less or this is greater, okay, than 2.25 inches or 6 millimeters, red flag. And then evolving, the mole is changing in size, shape, or color. So it started as little and then it's grown in a small, or the shape and color of it is changed as well. So if these are caught and treated early before it advances and spreads or metastasized, it's highly curable, but sometimes it's not always caught and treated early. So these are cancerous neoplasms present in the dermis and the epidermis. I want you guys to look over chart 61.4. This talks about the risk factors for development. Obviously, sun exposure, large moles, histories of severe sunburns, family histories of having melanoma. Again, those manifestations are changes in the mole or a new growth, that dark red color or it's mixed colors, the size of it, and regular shape. It's rapid growing. Sometimes patients will say they itch and obviously bleed. When they scratch it, bleed easily. So the treatment for that is going to be surgical excision and then chemotherapy, depending on chemotherapy and radiation, depending on the staging of the lesion. And then obviously if it's metastasized, then that would be, you know, the decision of the oncologist and dermatologist on how to proceed to treat that. If it's metastasized, just like any other metastasis, they would come up with a treatment plan for that. So just know your risk factors for melanoma, your prevention, what the moles are going to look like. Okay. All right. Ooh, I have 30 minutes. Looks like I am, was that 33 minutes on that recording, so I think I did pretty good. That's all I have for you guys. Again, skim over this chapter, read over it, but I wanted to kind of narrow down what I felt like was important for you to know, what's good to know, what's need to know out of this chapter. I'm going to, again, assign the pre-reading lecture, so please read, complete that before you come to class on Thursday for chapter 61 and 62, and be prepared for a quiz. I'm going to give a quiz first thing on Thursday morning, so make sure that you are prepared. Okay, you guys enjoy your day off, and I will see you Thursday. Thanks.